So I'm going to talk about KRAS. I've heard a lot about somewhat more obscure mutations and molecular abnormalities. KRAS is scarcely obscure. I think the first question, is it prognostic or predictive? And the second, perhaps bigger question, is it actionable? So my disclosures, I've been accused of pharmaceutical promiscuity, and this is proof positive. But I play no favorites, so, wherever the traffic can bear. And again, we've known about KRAS for quite some time, since the late 80s. And as yet, we have no FDA-approved drug for this abnormality. It's present on roughly a quarter of patients with advanced non-small cell, quite a bit more predominant in adenocarcinoma compared to squamous. And of course, it mediates tumor cell proliferation, survival, and metastasis through a number of pathways, but the two dominant ones are RAF-MEK and ERK, and then PI3 kinase and the mTOR pathway. But regardless, the big issue is whether this is really a driver or a backseat driver, and I think that remains to be seen. KRAS is not a single entity. So if we look at colon cancer compared to lung cancer, and particularly look at codon 12, you see a much higher proportion of codon 12D abnormalities in colon compared to lung. Conversely, a much higher proportion of codon 12C abnormalities in lung compared to colon. If we look at codon 13, again, more codon, virtually all of the colon cancer mutations are 13D, less than half in lung cancer, whereas codon 13C is more dominant in lung cancer. So even though both entities, both malignancies feature KRAS mutations, they're not the same. When we look specifically at lung cancer, former smokers are far more likely to have KRAS mutations than never smokers, and current smokers are even more likely than either of those other two groups to have KRAS mutations, on the order of 30–35% for current smokers who are diagnosed with lung cancer. And again, as we've seen between colon and lung cancer, there are differences in KRAS distribution between smokers and never smokers. So the never smokers far more likely to have G12D mutations, 56%, compared to 14% in former and current smokers. Conversely, G12C and 13% compared to 42% in smokers. So whether this has any bearing on activity or outcome remains to be seen, but it is not a uniform abnormality. Prognostic significance of KRAS. Early studies, particularly in surgical series, suggested that patients who had KRAS mutations did worse, but there are very small numbers in these efforts. More recent trials, JBR10, to recall, is the phase 3 trial that compared vinorelbine platinum to observation in the adjuvant setting. And then 4592, a rather old ECOG study, it looked at N2 patients comparing radiation or etoposide platinum radiation. In both of these studies, KRAS was not prognostic. The p-values are nowhere near significance. A very interesting analysis was mounted by Francis Shepard and Ming Cao and others called the LACE biocorrelative analysis. If you remember from Tracy's talk yesterday, the LACE analysis, the lung adjuvant cisplatin evaluation, and they actually looked at tissue, patients who had samples available for KRAS analysis. Nearly half of all of those enrolled on these platinum-based trials actually had sufficient material for KRAS. And you see the overall incidence of KRAS mutation in the adjuvant setting here was nearly 20%. Curiously, somewhat higher in the North American population, JBR10 and CLGB, 25–27%. It's not terribly surprising because adenocarcinoma is a bit more common in North America compared to Europe, the ANITA and YAL trials, and squamous is far less likely to have KRAS mutations. So first when I saw this distribution, I was a little bit curious, but it seems to correlate with underlying histology, and that's borne out. So it's been said that squamous never has KRAS. That's not true. About 6% do, but amongst adenocarcinoma patients who were resected, it was over a third of patients. And then the NOS category, about 23%. So that's how we get the total of 19.7%. Is it prognostic? In short, no. Whether we're looking at squamous, adeno, NOS, or the total group, absolutely no prognostic effect for KRAS mutation on outcome in the context of these prospective randomized trials. What about KRAS in conjunction with other mutations? This is the prognostic effect of KRAS and EGFR wild type, and again, you see no bearing on outcome, whether patients are KRAS wild type or KRAS mutated. If you look at a double mutation, the p53 is ubiquitous. Over 50 to 60% will have some abnormality of p53. KRAS together, perhaps a slight trend toward better outcome, but the confidence intervals overlap unity, and this is a very small series that actually has double mutations. What about the different codons of KRAS? So 12 versus 13 versus wild type. Again, no major difference in overall survival, or the different variations on codon 12, and again, no major difference in survival. So, is it a marker of adverse prognosis or not? And I would argue it's either very weakly adverse or not at all. This is a forest plot of various studies that have looked at the influence of KRAS on outcome. It's either a wash or slightly negative. It is never positive. So if you have KRAS mutation, there is no series that I'm aware of where people have done better, but generally about the same. And we've recently looked at our own data at Penn, specifically in patients who harbor KRAS mutation, just correlating activity of chemotherapy. And there might be a month or two decrement in survival, but it comes nowhere near statistical significance. This group does as well or as poorly with standard chemo plus or minus bevacizumab as the KRAS wild type group. Is it predictive? Can you actually use KRAS to determine whether a patient's going to respond to an EGFR inhibitor, be it a TKI or one of the antibodies? Well, we'll look at a bunch of studies that have really contributed to the literature, and if you come away confused from this, I think that'll be the appropriate reaction. So here's KRAS mutation in TRibute. To remind you, TRibute was one of the first phase 3 trials looking at chemotherapy plus or minus erlotinib. I believe it was Pac-Carbo. And intriguingly, small numbers, only about 25 patients, but if you had KRAS mutant and you got erlotinib in combination with chemo, you actually did worse than KRAS mutants who got chemo alone. Now, it wasn't significant because the numbers are small, but clearly this group seemed to be doing worse. The wild types did about the same, whether they got chemo alone or chemo plus erlotinib. The same trend was seen in the original BR21 trial. Remember, this was the trial that led to erlotinib's approval in the second and third line setting, PS 0 to 3, erlotinib versus placebo. KRAS wild type, you see an advantage for erlotinib over placebo. KRAS mutants, no obvious advantage, but again, very, very small numbers. So you take this with several grains of salt. The Atlas trial, Tracy and others had mentioned earlier. To remind you, that's the trial in patients who have benefited from bevacizumab and get Bev plus erlotinib versus Bev and placebo in the maintenance setting. And in the wild type group, we see a statistical advantage for PFS for the combination. For the KRAS mutant group, no such advantage seems to exist. And then the Saturn trial, which is the straightforward erlotinib versus placebo maintenance trial. In this case, unlike the Atlas trial, which is an analogous trial because it's still comparing erlotinib versus placebo, no major differences in outcome, whether we're looking at KRAS mutant or KRAS wild type. Again, this is the tyranny of relatively small numbers. When you get into smaller analyses, it's not surprising that results can go one way or the other. The same holds true for direct comparison for, in this case, gefitinib, another EGFR TKI versus chemo. Docetaxel in the INTEREST trial, which was a huge effort, absolutely no difference in outcome, whether patients had KRAS mutation or wild type. The survivals are essentially identical with totally superimposable curves. And what about EGFR monoclonal antibodies? So as you're well aware, in colorectal cancer, mutant patients, cetuximab and panitumumab have no indication. It's the wild type group that seems to have a benefit, actual PFS or survival benefit with the use of monoclonal antibodies targeting EGFR. Does the same pattern exist for non-small cell lung cancer? Well, BMS 099 was the phase 3 looking at Pac-Carbo with or without cetuximab. And unlike colorectal cancer, we see no such pattern. The wild type and KRAS mutant groups, same basic outcome, no difference for overall survival. FLEX was a positive trial looking at vinorelbine cisplatin with or without cetuximab, which I think we may have alluded to earlier. The EGFR H-score group that was high, the high HC group seemed to have a preferential benefit. KRAS is not predictive. So unlike colorectal cancer, wild types do not seem to have a preferential advantage. By the same token, the mutant KRAS group, no significant survival advantage. And here the hazard ratios are virtually unity. Can you predict a benefit for adjuvant chemotherapy? Well, there may be a trend. Anything under 1 is a potential survival advantage, but note the p-value here is not significant for the wild-type group. For KRAS mutant, a complete wash. Is this evidence sufficient to withhold adjuvant chemo in patients with KRAS mutations? I would argue strenuously not. This is post hoc analysis, limited numbers. We have to hold that sort of decision-making to an extraordinarily high level of evidence before we withhold treatment. And if you just look at the adenocarcinoma patients in the LACE bioanalysis and compare wild-type to mutant, identical hazard ratios. So the bottom line is it's not a useful marker in terms of predicting it. Certainly, we tend not to use erlotinib as readily in this group, but I wouldn't absolutely exclude it. Inconsistent results. It's a weakly negative prognostic variable in the surgical setting. More recent studies, particularly in the context of systemic treatment, have called this into question. KRAS wild-type patients have somewhat greater relative benefit with the TKIs compared to mutant-positive patients in the placebo-controlled trials, but KRAS mutation does not reliably predict an inferior outcome. And unlike colorectal cancer, neither wild-type nor mutant KRAS has any bearing on outcome in patients receiving the monoclonal antibodies in combination with chemo. I'll finish up with KRAS as a therapeutic target and look at 3 potential areas of interest. First, Helen alluded to this earlier. Tuvatinib, or ARQ-197, has been looked at. To remind you, this is a non-competitive oral inhibitor of MET with broad-spectrum activity and non-small cell xenografts. In vivo anti-tumor activity for this combination with TKIs is greater than either agent alone. It's quite safe in combination with erlotinib. This is the randomized phase 2 that Helen had alluded to, isolating the role of tuvatinib versus placebo in combination with erlotinib. Fairly large study, almost 170 patients, pretty much in the BR21 population. So 1 or more prior chemotherapy agents, no prior EGFR, metastatic disease with reasonable performance status. If you remember, overall, the PFS was significantly improved for the combo. And if you look specifically in the non-squamous population, those differences are even more pronounced with a doubling in PFS and about a 3-month improvement in overall survival. They did do a biomarker correlative, so 15 patients out of about 75 or 70 or so were KRAS positive. You see some overlap with MET amplification, absolutely no overlap with EGFR mutations. And here are the forest plots. And although it's very small numbers, 15 patients total, there seems to be a major PFS advantage for the KRAS mutant cohort with a hazard ratio of 0.18. So this has been looked at, and here are the actual curves for PFS in that study. Again, the p-value of 0.01 with just 15 patients. You see about a 3 to 4 month improvement in median PFS. So the Marquis trial actually addressed this issue. This was the randomized phase 3, looking at erlotinib versus erlotinib and tuvatinib, a double-blind, placebo-controlled effort. It was a huge trial. It accrued, I believe, over 1,000 patients. We'll look at the numbers shortly. Press release last year indicated that the trial was negative. This was just presented a month and a half ago at the ECHO meeting, so I'm free to show you these slides now. And in fact, PFS was significantly improved, so tuvatinib is having some effect in combination with erlotinib, but that did not translate into an overall survival advantage. Roughly half of the patients who were assayed, 25 to 28% of those who were assayed had KRAS mutations. So this is in keeping with what we've expected. 10% or so were EGFR mutant. About half or so who were assessed had high MET status. And unlike the randomized phase 2, KRAS has no bearing on outcome. And these are much higher numbers, so 280 patients with a mutation. So the only factor here that seems to be predictive, and I haven't shown you the curves, is MET, high H scores for MET. mTOR inhibition has been looked at as well. Ridafrolimus is an inhibitor of the molecular target of rapamycin. This is a randomized discontinuation design in KRAS mutant non-small cell. Subjects received 2 months of this compound 5 days a week, every week. The primary endpoint was PFS after randomization, so responders continued treatment, those who progressed stopped, and the stable disease patients were then randomized to placebo or continuation of ridafrolimus. And 79 patients, only about a third of whom had stable disease at 8 weeks. Overall response rate was paltry at 1%. But intriguingly, there was a statistically significant improvement in PFS compared to placebo in that stable disease group. You see a doubling from 2 to 4 months, and in fact, a borderline significant improvement in survival, 18 months versus 5 months. Again, very small numbers. Take this with major grains of salt. Only 28 individuals. We've seen how we've gone wrong with the KRAS mutation analysis in the Tivantinib trial. I'll finish up with the Mek inhibitors. Passiani last year at ASCO presented the phase 2 double-blind randomized study of selumetinib and docetaxel versus placebo and docetaxel exclusively in a KRAS mutant population. Now, some background, selumetinib and other agents of its ilk is potent selective allosteric inhibitor of MEK1 and 2, and there tends to be a much greater inhibition for selumetinib in both BRAF and KRAS mutant cell lines. So they are shown in red and blue here, and you can see that these cell lines tend to be much more sensitive to these compounds. And remember, selumetinib is targeting one of the enzymes down the protein cascade. Selumetinib has shown clinical activity in the second and third line setting, although it was not superior to pemetrexed. And phase 1 trials have shown that this combination with docetaxel has a manageable toxicity profile. And these are preclinical data looking at a KRAS mutant xenograft and the combination looking better than either agent alone or the control. So this set the stage for a randomized, double-blind, placebo-controlled trial isolating the role of selumetinib. Very ambitious, small numbers, but their primary endpoint was survival. The usual secondary endpoints. Here are the demographics, and as you'd expect in a KRAS mutant population, a high concentration of smokers, only about 10 or 11% were never smokers, a slightly younger population, just under 60, and most, but not all, had adenocarcinoma, over 80%. You see a statistically significant improvement in progression-free survival with about a 4-month advantage, 0.014, and it's certainly a trend toward improved overall survival. The hazard ratio here is 0.8, an early advantage that seems to dissipate by about a year. P-value is only 0.21, but again, it's only about 80 patients, so I think it's expecting a lot to see an actual survival advantage. Disease control rates are clearly better for the combination, and as is overall response rate, a whopping 37%. If we look at progression-free survival, it's 6 months, 37% versus 16% in the control group. It has toxicity, more GI toxicity, particularly nausea, vomiting, and diarrhea, more peripheral edema, more rash, particularly acneiform dermatitis and stomatitis compared to the placebo group, and a higher incidence of febrile neutropenia, 18%, which is really skirting on the edge of unacceptability. This has laid the groundwork for a phase 3 prospective trial, essentially the same study design in KRAS mutants, and this trial is ongoing and hopefully will address whether it's the first definitive trial for a Mek inhibitor in advanced non-small cell for KRAS mutants. There are other agents in the same cohort. Trametinib is another reversible inhibitor of MEK1 and 2. This was a phase 1 looking at a number of cohorts, including pancreatic cancer, BRAF mutant melanoma, and KRAS mutant non-small cell. Quite a bit of activity across the board with response rate of about 40%. The KRAS mutant non-small cell group, 2 of 14 had bona fide responses with single agent, and 7 additional patients were stable. At this year's ASCO, there were at least 6 or 7 presentations during the poster discussion that focused specifically on KRAS mutations, most centering on trametinib. So trametinib in combination with docetaxel, showing response rates very similar to selumetinib and docetaxel, a little bit lower, but certainly higher than we typically see with docetaxel alone, and single agent activity for trametinib that we're not seeing with selumetinib. And here are the waterfall plots for the comparative trial of docetaxel or trametinib in KRAS mutants, and they're pretty similar. So a single agent non-chemo drug working in KRAS mutants. Again, median progression-free survival seem to be equivalent in these two groups. So I will end here. KRAS mutants have been associated with worse prognosis, although this association is inconsistent. KRAS mutations associated with lower response rates to EGFR TKIs, but the impact on progression-free and overall survival is unclear. No association between KRAS mutant status and benefit from the monoclonals. Several therapies that look encouraging in early trials. Certainly the Mek inhibitors, as I pointed out, rodolfuralimus, but very limited single-agent activity and may potentially have a role as maintenance therapy. And finally, for the first time, a prospective trial that suggests a clinical benefit for KRAS mutant non-small cell in the phase 3 is ongoing. So I thank you for your attention, and I want to summon Dr. Brezhnova back up to the podium. Thank you.